get things started tonight, all right? We are starting later than normal. It is 8 p.m. Eastern time. We were supposed to be in Jackson, Mississippi, but due to medical reasons, we had to cancel the event in Jackson. So for those that are online right now, again, my name is Stuart Schlossman. This is a Compass to Care MS program. This Compass to Care Rural America and the regions beyond, okay? And tonight, again, my name is Stuart Schlossman, president and founder of MS Views and News. I too am an MS patient. So tonight's sponsors of this great event, we have Genentech, Biogen, Bristol-Myers, Squibb, Sanofi, Genzyme, EMD Serono, and I don't know if I already said it, but Novartis too. I can't keep track of everything right now, okay? Dr. Aaron Boster is replacing who we were supposed to have online tonight, and I do thank Dr. Aaron Boster for being here. Our topics for discussion tonight are understanding the invisible symptoms of multiple sclerosis, a little bit about MRI, disease progression, and access to care. Dr. Boster will be speaking for 30 to 35 minutes, and then we will do Q&A. So if you have any questions, please use that orange tab at the top of the scroll, or top of the toolbar, all right? Type in your questions, anything about multiple sclerosis or multiple sclerosis and COVID, and Dr. Boster will be able to answer all of these questions, all right? So I'm going to let him take it away, and I will be back on in about 30 minutes. Thank you, Doctor.
Thank you, Stuart, very much for the invitation. I'd like to thank MS Views and News for creating this opportunity to educate tonight. As always, my name is Aaron Boster, and thank you for learning about MS with me. Tonight, I'm really excited to talk to you about the invisible nature of multiple sclerosis and how we can make the invisible become visible. After a short didactic discussing the invisible nature of MS, we're going to open up the lines to questions. There's been questions that people have been submitting all week, and there's more that are pouring in. Stuart will be reading them, and I'll be knocking them out. So I'm excited for the next hour and a half of our lives. Let's jump into a discussion about the invisible nature of MS. We may even go as far as to say that MS is an invisible disease. And I'm going to talk to you tonight about how the diagnosis is invisible, how the symptoms are invisible, how the damage done, the pathology is seemingly invisible, and how our treatment responses in some ways are in fact invisible. And we're going to shine a light on that, and we're going to turn it on and make it visible. So let's jump in. For starters, I want to talk about the diagnosis of MS and the experience that families have shared with me over the last decade and a half, talking to folks as we work through the diagnostic process. Oftentimes, they're befuddled, they're confused, they don't yet understand everything that they're hearing. We'll take an example of someone that suffered an optic neuritis in their late 20s, very common presentation of MS. So their eye hurts when they move it, and they can't see very well, and they clean their glasses and it doesn't work. And it goes on long enough that they're brought to the attention of their eye doctor, who looks in their eye and says, oh, wait, there's something wrong. Go see the ophthalmologist. So the ophthalmologist looks in the eye, and about this time, the eye's starting to get better. The ophthalmologist says this could be an optic neuritis. That sounds like a new term for someone newly diagnosed. Sends them to the neurologist, who says, hey, we need to get an MRI. And then the neurologist comes back and says, hey, you have MS. And here you are in your late 20s, healthy as a horse, and you had this eye thing, and then suddenly someone's telling you that you have this condition, this neurodegenerative neurological condition that you've not heard of before. And oftentimes the patient will reflect, they feel fine. I've had patients say, doctor, I feel better than you look. And it really is challenging at first for someone to grapple with the fact that, in fact, that eye problem they had, that optic neuritis, is the beginning of a condition that they're going to live with the rest of their lives. It appears invisible at first. Now, how do you make the invisible visible? I think there's a couple things that are really, really important. Number one, after we're done taking a careful neurological history, we need to do a full-blown neuro exam. And when we do an exam, we're looking for abnormalities. We're looking for a brisk reflex, or a weak leg, or a numb hand, or a clumsy arm. And we're going to document what we see. And I'm going to come back to that. And then we need to get MRIs. And when we are ready to share a diagnosis, I think that we have to walk through the elements of the history which caught my attention and explain to them how what they described is in fact an MS attack. Then we go through the exam and I tell them, this was abnormal on your exam. Remember when I was doing this and it was harder with that hand? Remember how you couldn't do that very well? Those are findings that support what you tell me, and that's abnormal. And then the critical element is to show them their MRI. It breaks my heart that many, many people impacted by MS are not shown their scans. And if you're listening to this call, I double dog dare you to demand to see your MRI scans. A picture is worth 1,000 words, an MRI is worth about $3,000. And so that's a lot of words and a lot of pictures and a lot of information. And seeing the brain damage, seeing the spots on the brain is a way of helping the human being understand that even though they feel fine, the eye got better, that this invisible introduction to this disease is real. And I think it's important to go through that process and to answer all the questions. I also think it's very important when making a diagnosis that you're not there by yourself, that you have your village, not just for support so that they can hear also, because they didn't see that your eye was problematic. To you, to them, looking at you, God, you look so good. And so it's confusing to them as well. Now, that's talking about the invisible nature of the diagnosis of MS. I now want to turn our attention to the invisible symptoms of multiple sclerosis. But I have to have a sip of apple juice to wet my throat before I do that. Now, how many of you on the line have heard, honey, you look so good. You don't look sick. And then I immediately want to say, well, you don't look ill-informed and dumb. The reality is that most of the symptoms that really, really impact MS significantly are invisible. And I'll summarize them by talking about the up theres and the down theres. The up theres and the down theres are very commonly impacted in MS. They're invisible, and oftentimes we hide them from others because it's embarrassing. So the up theres is my way of saying thinking and memory, energy, and mood. Thinking and memory, energy, and mood are very, very commonly impacted by MS and completely invisible. And so the most common symptom in MS is fatigue, a profound and overwhelming fatigue that other people don't understand. And when you say to your spouse, honey, I'm really tired, they say, oh yeah, me too. Well, I don't think they have an understanding of the intensity of the fatigue. The best way I've ever been able to describe it to a spouse is as follows. Work Monday, and Monday night after dinner, stay up all night, don't go to sleep. Watch my YouTube channel. We got 400 some videos, watch half of them. And the next day, you haven't slept, take a shower, go to work. Work all day on Tuesday, come home, eat dinner. But don't go to bed Tuesday night. Tuesday night, stay up and watch the rest of my videos. And Wednesday morning, we'll go for a walk around the block and we'll talk about what it feels like to be tired. Now, you can write in the chat whether or not that resonates with you as an invisible symptom trying to help others understand. The same thing's true with mood. People impacted by MS are twice as likely to experience anxiety, and they're twice as likely to experience depression, and yet that's invisible to the outside view. And it can color the whole world gray and make you terrified, and yet, honey, you look so good. The third up theres that we talk about, after we talk about energy and mood, is thinking and memory. And thinking and memory is impacted in over 70% of people with MS. And this is not an Alzheimer's dementia where you don't know who you are or what someone is, but it can deal with difficulty with processing speed. The word's on the tip of my tongue and I can't think of it. I can't multitask the way that I used to. I can't keep a list straight in my head. I don't do well under pressure. And those are the cognitive impairments that we see in MS, but they look like you're just not trying, or they look like you're not paying attention, or they look like something else, not the disease, and it looks invisible. Now, it's not just the up theres that are invisible, the down theres are invisible also. What are the down theres, you say? Well, you know, bowel, bladder, sexual function, you know, the down theres. And it's not uncommon that people impacted by MS have difficulty controlling their bowel function. Very commonly, they're terribly constipated. I have patients that move their bowels once a week, once every 10 days. They're in excruciating pain. The bathroom is a terrible place to be. They have to stick things in places they don't want to and desperately try to poop, and nobody can see it. Similarly, it's not uncommon that people impacted by MS can develop difficulty controlling their bladder. Overactive bladder is very common. Got to go right now, and if you don't move, I'm going to go anyways. I couldn't get my pants down in time before I started. Or the other problem that people have, they're waking up all night, nocturia, constantly running to the bathroom. Another common problem with bladder is the opposite. It's retention, where you go and then you have to go 5 minutes later, or you stand up and you have to sit right back down and pee some more. And you can't empty your bladder all the way. And you're a risk for UTIs. And in fact, your bladder can fill up so much that you just lose all your urine. Completely terrifying, completely humiliating, and completely invisible to the outside observer because, honey, you look so good. Same thing with sexual function. There's very few things in life, aside from maybe like a good meal, that is a better indicator of quality of life than sex. And MS can impact sex. MS can make you have dyspareunia, which is a terrible word that means sexual sensation actually causes pain. You can have difficulty with arousal in general, and it can really create strife in a marriage because you just don't feel all that sexy. You can have difficulty with obtaining an erection or becoming adequately lubricated for the mechanics of sex. And in some cases, orgasm can become challenging or darn near impossible. And that is a massive destroyer of quality of life, and yet it's completely and utterly invisible to the outside observer. Now, the good news is bowel, bladder, sexual function, the down there's, and thinking, memory, and energy, the up there's, are completely treatable. I have a pill for every ill, and I have a pill for every one of those, and I have therapy that you can do for every one of those if you don't want to take a pill. But you got to let me know that it's happening, because otherwise I can't help you, because I can't see it from the outside because of its invisible nature. Now, then we've talked about the invisible nature of the diagnosis. And we've talked about invisible symptoms, or at least a couple examples of invisible symptoms. I could talk about invisible symptoms for well over an hour, but we're now going to shift gears and talk about another invisible aspect of MS, and that's the invisible nature of the damage, the pathology of multiple sclerosis. It's good apple juice. So the way that MS affects you is by causing acute bouts of inflammation. So these naughty autoreactive white blood cells cross the blood-brain barrier where they gain access to the supercomputer, the holiest of holies, the brain, and they attack it, thinking that it's a foreign invader. And they attack it using inflammation. And if the attack occurs in an area where there's no workaround, then you have an attack. You go blind in your eye because the optic nerve is really thin, like as thin as my pinky. And if it gets inflamed, it doesn't work. But the majority of the brain is much more plastic, is the word that we use, much more robust and able to rewire quickly. And so you can have lots and lots of spots that don't manifest symptoms. And you may get an MRI and you haven't had an attack, and yet the doctor says you have new lesions. I have new lesions, I didn't feel anything. And that's a problem, because sometimes doctors don't get MRIs, or sometimes they don't get an MRI of the spine. And the brain looks okay, but they're not looking at the spine, which can also be affected. And here's the kicker. When you develop a new spot, you pay what I call the devil's price, because you pay twice. So when you have the spot, and by the way, when I say the word spot, I need to correct my language, because an MS spot is actually evidence of brain damage. So let's call it what it is and say, when you have an attack which causes brain damage, your body tries to rewire. And so it'll figure out a way to work around, and then you will regain a function. You get better. But when I get to the MRI, there's still structural damage. And as you age and as your brain ages, those lesions start to wear out. And 10 to 15 years later, you can start to have progression of disability independent from attack from those areas. I want to use an analogy to make my point. Now, I don't own a firearm, all right, but pretend I owned a shotgun. All right, and now I'm going to blow a hole in that wall. All right, so now the wall behind me's got a big hole in it. And I'm in my house, and I'm allowed to leave the hole there if I want. And so I just leave it there. In fact, I put a picture frame around it. That's when I blew a hole in my wall. And this house is about 100 years old. And so let's fast forward another 50 years. And the materials in my house are starting to age. Which wall in this room falls first? Right? The one with the structural damage falls first. And that's the same thing that happens when you have brain damage. So when you have a new MRI lesion and you feel fine, you're not having any problems, it's not okay. It's not okay because that brain damage will then, you pay the devil's price as it wears out and as you develop problems 15 years later. Now, what do you do about that? You treat early, a priori is the doctor word, ahead of time. So we don't take an MS medicine to remove symptoms that we already have. They've already occurred. You don't take a birth control pill to get rid of the 3 kids you already have. If you have 3 kids and you start birth control, you still have 3 kids. You take a birth control pill to prevent an unplanned event, an unplanned pregnancy. And you take an MS disease modifying therapy not to get rid of your old symptoms. Those are already there. It's to prevent new symptoms from occurring and to prevent new brain damage on the MRI. And so by taking that medicine, you're really setting the stage for a much better life 15 to 20 years later. Now, we've so far today talked about the invisible nature of the diagnosis. We've talked a little bit about the invisible nature of MS symptoms, using examples of the up there's and the down there's. We just finished talking about the invisible nature of MS damage to the brain and spinal cord, seen on the MRI, not clinically until years later. And the last aspect of invisible nature I want to talk about is the invisible response to treatment. When you have a headache and you take an aspirin, your head feels better, and then you say the aspirin worked, right? Because you just took the aspirin, now your head feels better. And many red-blooded Americans expect the same from all medicines. They expect, I take a medicine, I get better, and I can see that I'm getting better. Not so with MS disease-modifying therapies. The first issue is something which is very hard to understand at first. It's called therapeutic lag. The impact of your disease-modifying therapy today is not helping you today. That impact will be appreciated 2 to 5 years later. And so if you take an MS medicine for several years and then you stop an MS medicine, you're not going to see the impact of stopping necessarily that second, but you're changing the trajectory of your disease. And the fact that you stopped will catch up with you, but not right away. It'll catch up with you later. There's a lag. So what you do today, the response lags, and that's so confusing to people. People take an MS medicine and sometimes they feel yucky and they say, I don't want to take this medicine because I feel worse on the medicine than off the medicine. That's not why they're taking it. As I mentioned earlier, you're taking the medicine to prevent unplanned events. And so if we look at a group of people with MS who take a medicine compared to a group of people that don't, the people that take a medicine, they are less disabled at the end of their life. They've accrued less neurological disability. They have less brain volume loss, brain shrinkage. They have less brain damage, and they fare better long term. But they're realizing that benefit 10, 20, 30 years later. When I talk to a young person newly diagnosed with MS or someone in my clinic who's struggling, I tell them, I'm not really trying to talk to you at 30. You at 30, you're doing fine. I'm trying to talk to you at 60 because you at 60 can't impact his disease the way that you can at 30. And the 60-year-old you is screaming from the future, you must do it now. Do it now for me later. Because of the invisible nature of treatment, it's not always straightforward. And so by taking a disease-modifying therapy, you're really investing in your own future health. And it's invisible now, but it's not invisible later. Today, we've talked a little bit about the invisible nature of MS. And I want to wrap up this short didactic talking about 5 ways that you can up your game and live your best life despite having MS. And I call it being 5 for 5 in your fight against MS. I want to leave you with the concept of being 5 for 5. And I hope that you are 5 for 5 right now. What is 5 for 5? Number 1, don't smoke stuff. Smoking increases the risk to get MS, and it speeds up MS by about 50%. Number 2, supplement low levels of vitamin D. I live in sunny Columbus, Ohio, where 7 months out of the year, there's not a lot of sun. And we want to drive those levels up above 50. And so if you can't bake in the sun, you can take a pill. Now, for you Floridians, being in the sun for 15 minutes shirtless is going to give you the equivalent of 5,000 international units of D3. And so maybe the best way to get sun is to literally go outside 15 minutes a day. It's also good for you to be outside like that. Number 3, after we talk about not smoking stuff and taking vitamin D, is to exercise as part of your lifestyle. And I don't expect you to become an MMA champion or a mountain climber, but I am asking you to find an activity that you don't hate, that you can do on a consistent basis for a long period of time. Could you do yoga once a week, every week? Could you go on a walk after dinner, a couple times a week? Could you do a water Zumba class? People impacted by MS that exercise as part of their lifestyle end up less disabled at the end of their lives compared to those that don't. Number 4, and being 5 for 5, is to take a disease-modifying therapy and make sure it's working. And number 5, and being 5 for 5, is an active daily practice of mindfulness, of meditation, of centering yourself in the now, just for a quick moment. We typically spend all day long running, telling us movies in our minds about what might happen tomorrow and thinking about the past and lamenting. And so the concept of mindfulness is to be present in the now. I will share with you that I've been practicing shower meditation. And if you think that's weird, I am. But I have a tradition of showering every morning before I go to work. And I've started to do something really cool. I sit in the shower, cross my legs, close my eyes, and I breathe for about 5 minutes. I go through a breathing exercise, and I have to tell you guys, I I open my eyes and I feel refreshed and I feel energized and I don't feel anxious, and it's the best way to start my day. So my name's Aaron Boster, and as always, I want to thank you for learning about MS with me. I am excited to open up the lines and invite Stuart to come back on where we can field your questions. Stuart, it's all you.
I'm back. Thank you very much. All right. So we have questions. People wrote in questions online. People wrote in questions as they registered for this program. If anybody else has any questions, please remember to go to the top of the scroll bar, okay, and click on the orange box and type in your questions. All right, it could be based on questions, answers that Dr. Boster is going to give to questions that are being asked, okay, or, come up with your own. All right, first one is from a person named Jessica. Can you discuss the clinical radiological paradox with clinical symptoms and neurologic, exam findings not matching 3T MRI and your feelings on 7T were available for clinical use?
Yep, so a multi-layered question. I love the question. The first thing is to introduce a term, clinical radiographic paradox. So a clinical radiographic paradox is a fancy Scrabble way of saying the human being doesn't match their MRI. Sometimes the human being has almost no disability when you examine them, and their MRI looks devastating with extensive brain damage from MS lesions. So those don't add up. Conversely, you can see someone with an MRI that doesn't look that bad, but their clinical course is devastating and they don't match up. And that's what we mean by clinical radiographic paradox. Now, when I see a patient who is doing right as rain, they're doing great, and their MRI looks scary, I tell them, our goal is that you never catch up with your MRI. Now, the person, Jessica, who asked the question, asks about using a 3 Tesla magnet. Now, outside of research, the most powerful magnets that are available are 3T. I do all my imaging on 3T. And simply put, it's a better picture. You can just see more. But that doesn't mean there isn't a clinical radiographic paradox. And here's the thing. When you have brain damage from MS, your brain rewires. Okay, so it's not like a stroke where that section dies and that's the end of the story. There's inflammation and the brain rewires around it. So you can look better than your MRI appears. Conversely, you could have one lesion in a really, really bad location, which is neurologically devastating, but it's only one spot. So I like to do my imaging on 3T, but I don't think that's the crux of the clinical radiographic paradox. Last comment is about the 7T MRI. So I used to be a professor at a fancy pants university, and we had a 7T MRI there, and I used to use it. It's a really fun tool. It's not prime time yet, and oftentimes you can get sections of the brain really, really, really good, but then other sections, the 7T is not there yet. So I don't think it's prime time yet, but it's a heck of a fun tool. Great question. Thank you, Jessica.
So I'm going to continue on that one, though. And so many people only know that they're getting 1.5, especially those in the rural areas around the United States. So can you tell us, what the difference is between 1.5 or your standard MRI and the 3T, which is what you're talking about now?
For sure. Absolutely. So the very best biomarker we have for MS is an MRI. So what's a biomarker? A biomarker is a tool to tell you about a human. So instead of cutting open your brain and looking at the lesions, that's dumb because you're using your brain, we take a picture of the structure of your brain. That's the MRI machine, and it teaches us about how you're doing. All right. And better or worse, it's the very best biomarker that we have. It's how we diagnose MS and it's how we monitor MS. And the quality of the picture matters. So when I think about someone in rural America, or I think of someone who maybe worked up in a community environment as opposed to like an academic center, I'm not worried that they're going to use a 1.5 as much as I'm worried that the protocol is bad. Now, when I talk about 1.5 or 3, I'm talking about the Tesla. It's the strength of the MRI. And I'll share with you that nobody on this call should have an open MRI 0.7 Tesla. That's a really, really low quality scan, and we miss stuff all the time. I would literally rather you not spend the money on an open MRI and use it for something else because that's how useful it is to me. It's not useful, and it's a waste of your resources. Now, a 1.5 Tesla scanner is not the strongest scanner, but a properly protocoled scan without gaps where you have complete coverage of the brain without big gaps, you can still have really good images. So I don't want someone to think if I have a 1.5, it's bad, and if I have a 3T, it's good. A 1.5 done properly can be fantastic, but it has to be a special MS protocol. And sometimes community scanners, they don't do that. So unfortunately, Stuart, I will oftentimes receive someone and they have scans and we have to repeat them because they weren't of good enough quality. The picture really does matter.
Right. So what about those that flip-flop? They go for their 1.5s and they all of a sudden they hear about a 3T that's available, but then they're uncomfortable with the length of time that they spent in a 3T machine versus their 1.5. And they say, oh, let me go the next time, I'll go back to 1.5. What does this do to what they're saying?
Flip-flopping is a problem for the patient because it limits our ability to interpret the studies. If you ideally want to get all of your scans on the same machine with the same protocol so that you're comparing apples to apples. And if you look at a scan that's 1.5 and a scan that's 3, you're going to see more stuff on the 3 Tesla potentially, and you're going to think that they got worse when in reality it was present, you just couldn't see it on the 1.5. So whichever one you're using, you want to stick with that scanner, ideally, and stick with the same protocol. Now, I would love it if all scans were done on a 3T all the time, although that's not realistic in the era that we're in right now.
All right, thank you for that. All right, switching a little bit. Patty writes, my MRIs haven't changed since 2012, but my symptoms are so much worse. What is happening? What does this mean?
So that is confusing to a lot of people, and it goes back to our initial conversation about the invisible nature of MS. And there are 2 manifestations of MS pathology. The first is an attack, where you have a new loss of function that lasts longer than a day, like the optic neuritis example that I gave earlier. But there's a second way that you can get worse from MS. It's called PIRA, or progression, which is independent from attack. And you don't have to have new spots to have worsening symptoms. Because as I mentioned earlier, the old spots as you age can wear out. And so it's naive to only look at the MRI as a yes/no for how I'm doing. When you assess a human being with MS, you really have to assess, in my opinion, 3 things minimum. Number 1 is the most important. It's what they tell you. Because you're a you expert. You know more about you than anybody else, and you'll know more about you than I will ever know about you. And so if I listen to you, you'll actually tell me most of the answers. So you'll tell me when stuff's not going well. And the second thing, or the second most important thing, is a toss-up between the MRI and what I call the MS Olympics, or the testing that we do to monitor MS, whether that be a PEG test or a neuro exam. And any one of those can be bad and it's not okay. So if you're doing great, not having attacks, and your MRI is clean, but your exam's worse, not okay. If your MRI is clean, but you've had an attack, not okay. My point here is we're monitoring you with 3 things. MRI is one of them. And just because the MRI is not changing doesn't mean the disease is not changing. It doesn't work like that. And if you're experiencing a worsening, that's real, and we need to try to treat that.
Okay, thank you. All right, again, switching topics. We're going to be flip-flopping back and forth, everybody. And again, for those that came in a little bit late, you are watching Dr. Aaron Boster, and you are watching me. My name is Stuart Schlossman, president, founder of MS Views and News. All right, going further, the next topic is a person named Jill is asking, can you discuss Botox for bladder incontinence, please?
Absolutely. So it's very common, unfortunately, that people impacted by MS can have problems with the down theirs, just like I talked about at the beginning of this discussion, including bladder problems. And there's different kinds of bladder problems. So one bladder problem is the bladder, which is a bag, spasms down to a tight little racquetball. And so you can drink half a Coke and it's full and you got to run to the bathroom. And you have symptoms of overactive bladder. Right. So things like I have urgency. I got to run to the bathroom because I can't hold it. Or frequency. I'm constantly getting up to go to the bathroom. Or nocturia. I'm constantly getting up. Or accidents where you wet yourself. And the first way that we try to treat that is really by behavioral measures. Increasing water and increasing frequency of bathroom trips is actually the tool that we use. But oftentimes in MS, that's inadequate, and we may try a pill for that ill. So there's a host of pills that work to help bladder. And you've even seen commercials, gotta go right now. And these medicines, they relax the bladder to make it bigger so that it's a normal size so you can hold a normal amount of urine. Sometimes, however, that doesn't work. And there's another tool that you can utilize in the urologist's office, and it's a game changer. It's really awesome. It's called Bladder Botox, and it is what it sounds like. The urologist puts you up in stirrups, and they take a cystoscope and they go in your urethra up into your bladder, and on the end of that cystoscope is a Botox needle, and they literally Botox your bladder, and it causes the bladder to relax, and it's fantastic. Now, one of the side effects that some people who have bladder Botox can experience is then they're not able to empty all the way, and they may have to use a catheter at times to fully empty their bladder. And before the people on the line say, oh no, I don't want to do that, let me share with you a story about a patient that I take care of, a fantastic woman who didn't leave her house because of her bladder. Like, she was not going to go outside because she was terrified to wet herself. And I tried the behavioral measures and it didn't work. And I tried the pills and it didn't work. And I tried like 5 or 6 different pills. We tried all kinds of different stuff. Nothing worked. She got bladder Botox and it literally changed her entire life. And she wrote me an essay about it. Like, she handed me a paper that she wrote. And what she shared was, in exchange for using a catheter discreetly in a public bathroom, she is fearless. She can go anywhere she wants because she knows that she's not going to wet herself. And she also explained the very best public bathroom is in Starbucks, because Starbucks, the bathrooms are clean and you can lock the door and there's plenty of room. And she carries these little catheters that collapse. You can hide them in your palm and they expand. They use them once and she tosses them out, and it's changed her life. And so Bladder Botox is a powerful, fantastic tool. I really like it. And Jill, thank you for asking that question.
And Starbucks has onesies, bathrooms. You're not sharing it with anybody.
Yeah. So a catheter is not a community tool.
Right.
It's unique to you, and many of them are one use. Now, some of them you can wash and reuse, but oftentimes nowadays they make disposable ones. Reuse it once and toss it.
Okay. So another person just asked, based on this dialogue, will the urologist be able to predict the need for self-catheterization based on other urological tests?
Yes. So when you see the urologist, they shake your hand, they talk to you, and then they get you in stirrups and they do an examination inside the bladder. And they can do all kinds of things to see how the bladder fills, how the bladder empties. I mean, they can really understand the dynamics of the bladder. And so they can help clarify for you, is there a retention problem? Is there not? And they can probably help you clarify if you're going to need catheterization. The problem, I said the problem can be a tight little bladder. There's a second option in MS, and that's not the bladder is small, but the outflow tract is tight. So the urethra that goes from the bladder to the toilet, it's like a swizzle straw. It's super tight, and it's like trying to drink a McDonald's milkshake through a swizzle straw. Like, you can't get it out. And so in that situation, there are medicines that open up the bladder, which is great. But in addition, sometimes that doesn't work and we have to use a catheter. And that can be a game changer. Again, that way your bladder's empty and you know that it's empty and you don't have to worry. And so if you go to the urologist, they can help you sort that out.
Great, thank you. All right, next, Diana asks, how long does the effect of Botox usually last or typically last? 3 months. Great, thank you for that. All right, let me take some questions that were written in prior when people registered. My primary care internist says that the contrast used for MRIs may be adding to my kidney function diminishing. Do you have any suggestion or additional information about this?
So it's true that gadolinium, which is the contrast agent in the MRI, is processed by your kidneys. And many hospital systems check kidney function before they'll give you contrast. And if they see that your kidney function is kind of suspect, they won't want to administer contrast. And so if you have a kidney problem, it may be appropriate not to give contrast. Now, I prefer all of my MRIs with contrast. I prefer because I learn more. But if I don't have contrast after the diagnosis is made, I can still make like a lot of my decisions. I would say I still learn 80–85% of what I need to know in a follow-up MRI without contrast. And so it's not a terrible, terrible thing. And I would not want to place someone at risk. Now, there are some maneuvers you can do with medicines and with hydration and stuff. But honestly, if you have a problem with your kidneys, I'm probably just going to tell you not to get contrast if I was ordering your scan. And there's still a tremendous amount that we can learn.
Great, thank you. Staying on MRI, a person writes, I can't have MRIs because my pacemaker is metal. Leads in my heart are now surrounded by scar tissue. Is there anything specific I could do or should be doing to track progression or the need for meds? It's hard to know what symptoms I have are MS.
You're spot on that when there's a metal device in your body, it can create a problem because it's not safe to image you because the MRI would heat up the leads. Now, in the modern era, for people that in the future will get a new pacemaker, some of them can be MRI compatible. Now, it's not just pacemakers that create a problem. Spinal cord stimulators, some are MRI compatible, some are not. In bladder stimulators, some are MRI compatible, some are not. And so you can end up with situations where you have metal leads in your chest or in your back or somewhere which precludes you from getting an MRI. And that's a real big pain in the tushy because we have become so dependent upon MRI to make our decisions. Now, we've had MS long before we've had MRIs. I mean, the first cases of MS were described in the 13th century. And so they didn't have MRIs back then. Heck, they didn't have MRIs in the 1970s. So we've been able to diagnose MS old school. And you can go back to Charlie Poser criteria in 1963, and you can use old criteria to diagnose MS. And you're really going to have to depend upon other measures. So what other measures? Well, one is litmus test of life. All right, you're a U expert, you share with the doctor what's up. Number two is neuro exam. And I think in someone that I can't image, I'm probably going to do more neuro testing than normal because it's one of the things I can look for, objective data. Another very powerful tool is the OCT machine, ocular coherence tomography. The OCT machine shines a laser in your eye, and it measures the thickness of the back of the eye. And the thickness of the back of the eye correlates to brain volume loss. And so it's like a poor man's MRI. And so that's another tool that we can use. My point is, we can still take care of you. We can still monitor you. We just lose one piece of information. And you're not wrong. It makes it challenging, but it can be done.
Okay, thank you for that. Going back onto the screen, Karen writes, do most people have to go on another drug after they do 2 years of Mavenclad?
Excellent question. So Mavenclad is a pill which is FDA approved for relapsing forms of MS, and it's a weird pill. It's a pill you take once a day for 5 days in a row, so like Monday, Tuesday, Wednesday, Thursday, Friday, and then nothing the rest of the month. So it's like a reverse birth control pill. And then on the second month, you take 5 days in a row, and then you're done for the rest of the year. So that was year one. And then on year two, you repeat once, 5 days in a row, wait a month, 5 days in a row, done for life unless you have new disease activity. Now, there's a trial called the Classic trial, which looked at some people they followed with Mavenclad for 10 years. Not everybody, but some people. And what they found was about 60% of people never needed retreated, because the way Mavenclad works is it's a micro-induction where it suppresses the immune response and kind of resets the immune system. And so some people didn't have disease activity after that. If you have disease activity after Mavenclad, just like any other disease-modifying therapy, then you open up the books and looks at what's available, and you may switch to something else. So in Mavenclad, if you take Mavenclad year 1 and year 2, the FDA says it's not allowed to take it year 3 and 4 because of risk. And so if you had an attack in year 3 and 4 and needed a medicine, we would pick a different one. But if you took Mavenclad year 1 and year 2 and you were boring in year 3 and year 4, nothing happened. And then in year 5 or after you had another event, you could take another course of Mavenclad. So I hope that answered the question. That was a really good one.
Good, thank you for that. Jessica writes, is it true that MS lesions typically occur around a blood vessel and that the initial inflammation, blood-brain barrier breakdown before the lesion can look like a vascular abnormal formation?
Yes.
Great. Next question. Bill writes, and I'm not quite clear on what Bill is saying because he contradicts himself. I have PPMS 20 plus years and I don't currently take a DMD. Oh, currently. I've taken numerous drugs over the years without apparent improvements, just constant decline. Should I start taking Ocrevus again? And sorry, I didn't understand your bill, but I understand it now, so that's great.
So my opinion is yes, and let me explain why. When we did the Oratorio trial, which led to the FDA approval of ocrelizumab for PPMS, we randomly assigned patients with PPMS to either get placebo, so dummy infusions, or Ocrevus. So half the people got, or 2 to 1. So 2 people got real Ocrevus and 1 person got placebo, but nobody knew what they were on, right? At the end of the trial, after 2 years, we unblinded. So we found out, oh, this group of people, they were on dummy drug. This group of people, they were on Ocrevus. At the end of the 2 years, all of the patients got worse. But the people with Ocrevus got 25% less worse. So Ocrevus slowed the progression of neurological disability. Now, going beyond that, we know that Ocrevus maintains hand function. We know that Ocrevus maintains cognitive function, and it slows disability progression. And so should you take a medicine to slow down your disease? In my opinion, yes. Is it going to make the disease not move forward? Unfortunately, no. But I think slowing it down by 25% is fantastic, and I vote that you do that.
Great, thank you. Person wants to know what are the differences between the 2 best drugs that he feels are Tysabri and Ocrevus. Which should he be doing, he wants to know.
I have no idea because I only know that you're a male. I don't know anything about your history. I don't know anything about your MS. I don't know what your exam looks like. I don't know what your MRIs look like. I don't know what your labs look like. I don't know what your spinal fluid looks like. I don't know what your social situation is. I don't know your COVID status. So I don't have any information to guide me. Now, if you want to mail me all of your records and labs and MRIs, I'll look at them all, and then we can do a 2-hour consultative visit. And at the end of that, I should be in a good position to share with you my impressions.
Great, thank you for that. All right, next, is dizziness, balance, and other issues part of invisible symptoms? I get strange looks from people when my balance is out of whack.
So it's a very common phenomenon, and there's a shirt that I love that you've seen before that says, I'm not drunk, I have MS. And there's a better shirt that says, I'm not drunk, I have MS. And then in small print, it says, okay, I'm a little drunk, which I think is hilarious. But the reality is that when you consume alcohol, so let's pretend this apple juice was actually bourbon, and you're consuming alcohol, you're really inhibiting your cerebellum, the balance center of your body. And so when someone is drunk and they stumble, that's because they inhibited the cerebellum. Well, unfortunately, in the setting of MS, you can have damage to the cerebellum, which causes the same phenomenon. And so it is embarrassing to some people when you stumble and people think that you're drunk. Here's a tip. Take a cane. If you have a cane, 2 things happen. Number 1, if you start to fall, you can throw the cane down and it'll support you. Number 2, the outside observer recognizes the guy that's having trouble walking, he's got a cane. He's probably not drunk, he's probably got a problem. And there's actually a third advantage. If someone acts sassy, you can crack them in the knee with your cane, and then they won't act so sassy.
That's right. That's right. Okay, great. Thank you for that. All right, next one. Person writes, I live in an Asian region. Many popular diets use ingredients that are not readily available or are just very expensive. Do you have any specific suggestions?
This has been very top of mind for me recently. Or actually earlier tonight, I conducted a journal club with a bunch of doctors. We reviewed a bunch of information about nutrition and diet and MS. So I don't think that you have to have a certain food to win in MS, but I do think that the diet matters. And I'll share with you my recommendations for diet, and then we can think about how it fits into the region that you live in. So I think people with MS should up their water game. I think most people with MS would fare better if they drink more water. I want you to drink 1 glass of water, and it doesn't need to be like this, all right? It could be like a normal glass of water with breakfast, lunch, and dinner. And then I want you to drink 1 glass of water between breakfast and lunch and between lunch and dinner. And I don't care which region you live in, I'm assuming that you have access to water, and then I want you to drink 5 glasses a day and up your water game. The second thing is I want you to avoid fast food. And I don't know if the region you live in has a lot of fast food. Where I live, there's fast food restaurants everywhere. It's disgusting, and that's not real food. And so I want you to avoid that. I want you to avoid heavily processed foods, which are really, really high in sodium typically. And I want you to avoid foods that have ingredients that you can't pronounce. If you follow those rules, you're going to be picking options which are really in your best interest. I think eating more vegetables and fruit is a really good idea. I think if you're going to eat meat, lean meat, and fish in particular is fantastic. And I think that you can find a healthy diet in any environment in the universe. I just want you to up your water game, avoid soda, avoid fast food, heavily processed food, fried foods, and foods with names that you can't pronounce.
Very
good question.
Thank you. Very good. Thank you. Next, not when, but where are we at with insurance covering serum NFL testing? And we're not talking about football, people.
Yeah, so NFL in my field stands for Neurofilament light chain. And I think I don't even know what it stands for in football, honestly, Stuart.
National Football League.
Oh, well, that makes sense, but I didn't know that. So Neurofilament light chain is a really, really amazingly cool test, which will soon be available, but it's not available yet. So when you have damage from MS, the neuron, and we'll pretend this pen is a neuron, it breaks, right? So all right, so the neuron breaks, and inside the neuron are a bunch of chains, heavy chains, medium chains, and light chains. And the chains are then released into the spinal fluid, and they float around, and then they get in the bloodstream, and they float around. And there's testing now to determine the amount of neurofilament light chains, in other words, the amount of damage that we can find. And the higher the number, the worse things are. And what we found is if you are on a medicine and it's not working, the neurofilament light chain goes up. The blood test shows you that it's not working anymore before you have an attack. And if you're about to have an attack, the neurofilament light chain goes up. And when you go on a highly effective medicine, the neurofilament light chain normalizes. So in the very near future, I think we're going to draw blood and we're going to tell you, hey, we need to make a change, or hey, we're doing okay. And I envision that we're going to check neurofilament light chain serum test, a blood test, 4 times a year. Now, the question was, when is that available? And my answer is, I don't know yet, but it's not prime time. And I can't wait until it's available because it's a game changer. I think it'll change everything. It's going to make us much better at managing MS.
Thank you. So Dr. Boster, the scholar, has his NFL. Me, the athlete or the person that likes watching football, would prefer a good quarterback option or a good flea flicker or a sneak or anything else, all right? And that will work for me, all right? But let's go back to the MS stuff. Next person wants to know if you could discuss aging and MS. Long topic. I need you to make it short, though.
So the bottom line is people with MS live normal life expectancy in the modern era, which means people with MS are going to get older. And you're going to have folks that used to be 30 and now they're 60, or people that used to be 40 and now they're 70 or 80. And people impacted by MS, when they age, they have a different set of variables and things to think about than the average person that's getting older. Now, there's a travesty in the United States right now where some MS doctors must have smashed their heads and they can't think clearly because they got it wrong, and they think that it's a good idea to stop medicine because of a certain age. And I think that's ageist, and I think it's abominable, and I do not recommend it. And so I'll share with you quickly a story of a 71-year-old that I take care of. She was my patient, and she left my practice for various reasons, went and saw another doctor who said, "Oh, honey, you're 71. You don't need to be on your medicine." And so she stopped, and she went from a cane to a wheelchair. And she came back to see me, and now she's back on therapy, and it breaks my heart. Bottom line is, older people with MS are people with MS, and we need to treat them as such. And as long as you have a nervous system that you like you have functions you enjoy, like seeing or orgasming or swallowing or whatever, I want you to keep that in mind. And if you have an immune system that can attack it, that's not okay. And so I want to keep you on therapy, at least until you die. After you die, we can stop treating.
Right. And I knew you were going to say that because somebody asked me the other day, when's a good time for me to stop my medication? And I said, well, I'm not a doctor. I can't tell you, but I can tell you what Boster would say: when you're dead. Okay, yeah, that's the time to stop your medication, and you won't care. And you won't care that you stopped.
Well, the drugs don't work after death. Like they're completely ineffective, so I don't use them then.
Right. Okay, so this goes back to a question from Karen now. How long do you keep people on Ocrevus if they're in their 60s? Then what drug would you typically recommend when you would stop it?
That's a really great question. How long do we stay on a drug? We stay on a drug forever unless one of 5 things happen. If you have an attack, that's not okay. If you fail the litmus test of life, meaning you're backing away from life's activities because of MS, that's not okay. If you have new spots on your MRI, that's not okay. If your exam gets worse, that's not okay. Or if you no longer tolerate or handle the risk of the medicine. So as a human being ages, the risk profile changes. And I don't think 60 is old at all. And so I would not consider stopping a 60-year-old's ocrelizumab at all. Like, I wouldn't do that. But if you were to do that for whatever reason, or if maybe I might do that in someone who's 75 or 80, we can adopt a concept of de-escalation, where you go from a highly effective medicine with maybe a risk profile that you're not as comfortable with to something that's maybe slightly less effective, but still very good, and it has a better side effect profile. And I'll share my bias. I really like the medicine Aubagio, teriflunomide, or the generic Arava, leflunomide. And these medicines are not amazing at stopping relapses. They're like okay at it. And they're not amazing at stopping new MRI lesions. They're okay at it. But they're really, really good at slowing brain volume loss, and they're really, really good at delaying accumulation of neurological disability, which is a perfect drug to place on the second half of the disease, the back half of the disease. So when I stop a highly effective medicine, I'm not stopping therapy completely, I'm de-escalating. And that, I think, is a very rational approach.
Okay, thank you. Next, very different topic. Is clinically isolated MS a thing? I was diagnosed in 2009, and so far my MS has been pretty manageable. Besides constant pain in my legs, I've had only 1 to 2 relapses in the early 2000s. I've read that after 10 years, relapse-free, you move to that. I don't know what that is. I guess back to CIS.
So I think there's a couple things to unpack in this question, Stuart. One of them is the words that we use, right? So clinically isolated syndrome is a very, very specific thing in our field. It's the very first event that may go on to become MS. So the classic example is a transverse myelitis or an optic neuritis or a brainstem syndrome. And if someone has a CIS, they're at risk of having MS. And if they have CIS with a normal brain MRI, with a normal spinal tap, they've got about a 20% chance to have MS, to go on to have a second attack and then be diagnosed with MS over the next 20 years. If they have positive spinal fluid, it's doubled. And if they have brain lesions, it goes up to 80%. And so The workup at CIS is very valuable prognostically to tell you about what's happening further. Now, the person actually says they've had a couple attacks, so that's not CIS. By definition, that's relapsing MS. And they share that they haven't had attacks in many years, which is great. But there's no rule that after 10 years X or at 10 years Y. And what they might be hinting at is this false concept of benign MS. There was this concept was propagated in part by folks in Rochester, Minnesota. And they had this idea that if you have 15 years of MS and your EDSS, your disability is less than 3, that's benign. And I call BS. Because number one, having an EDSS of 3 is not benign. Those are people that can't exercise normally, that impairs their quality of life. And if you study people out like that, a third of them go on to have active disease. So I think that benign MS is a misnomer, and I think it does a terrible disservice to people impacted by the disease. Thanks for that question.
Thank you for that. For those that are on here a little late, I'm sorry that you may have come in late. This video, this recorded program will be on our YouTube channel within a week, hopefully. We are a little bit behind right now because we are doing 11 virtual programs a month, okay? And it's really absolutely fantastic for the MS community that we're able to divide up and be able to do all these different programs. But if you go to our website, you can go to the center column of the website page, and you can see all the programs that we have coming up in August as well. Again, this will go onto our YouTube channel. I'm going to say a little bit more than a week at this point in time, and you'll be able to see everything that Dr. Boster spoke about before the Q&A and what he has discussed so far since we began. And if you don't know me, well, I don't know where you've been. Seriously, okay? You'll have to go back and go to our YouTube, go to our website. I am president and founder of MS Views and News and also an MS Patients, okay? All right, so we have a few more questions on written out as well as on the screen here, and I know we'll be able to finish them all, all right? We got about 15 minutes left, everybody, and we're just going to get through this, okay? All right, so Patty writes, so what are the best methods to support secondary progressive MS?
So, Patty, when I talked about that 5 for 5, that counts in any form of MS. Don't smoke stuff. Supplement vitamin D. Exercise as part of your lifestyle is very, very important in secondary progressive MS. Take a medicine, because the medicines slow disease progression. They slow brain volume loss. They do more than just treat attacks. And make sure you're taking a moment each day to manage stress and to practice mindfulness. That 5 for 5 will serve you well with PPMS or with SPMS or with RMS or with CIS.
Okay, great. Next, is it true that the final degree of recovery after an MS relapse will be the same without steroid treatment? Thoughts on benefits of steroids for relapses? The side effects of steroids can be debilitating themselves.
So there's data that's old data from the optic neuritis treatment trial that if you treat with steroids or not, it doesn't change the long-term outcome, and I call BS. Because they didn't know what we know now about the details of the retinal nerve fiber layer. And when you have an optic neuritis, you take a hit. And it's my belief that giving anti-inflammation via steroids quells that inflammation earlier and saves brain tissue. Now, I can't prove that to you actually, all right, because the data is kind of like murky, but it's my strong belief that we want to do what we can to quell active inflammation. I don't want an enhancing lesion burning literally a hole in your brain. And when I give you steroids, I quell that. So steroids are a necessary evil. They are evil. They're very not fun. They cause significant side effects, and I hate that, but I hate MS more. And if you have an attack, I want you to tell your clinician, all right? And we'll talk about steroids, and you're the boss of you. You can say, I don't want to do it. And I'll say, okay. But I think that we need to at least have the conversation, because I think it's really important. Just to make that point, when I have someone in my clinic who has an MRI and they have a new enhancing lesion on the MRI without symptoms, I give them steroids, because that enhancing lesion, that brain damage in their brain scares me, and I want to quell it as fast as possible, and I do that with steroids.
Okay, thank you. Next question. How do you know when pain or health problems are related to MS or are from unrelated cause or problems?
So that's a great question. Human beings experience stuff. We experience symptoms, and we don't know why. So if your leg hurts, you don't know why it hurts. And it may be coming from MS, it may be coming from something else. So this is why it's very, 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 very important that when you have a new neurological symptom, you're seen by your doctor. Your doctor sees you. And I'm going to give you an example. A couple years ago, a patient called me and said, I'm having an attack, I need steroids, like on a telephone. I said, really? She said, yeah, my leg is numb and I'm having a little trouble. It kind of feels like stiff, like swollen. And I'm having an attack, and I've had this before, and I need you to call in steroids. And I said, absolutely not. You need to come into the office so I can examine you. And she said, I don't want to do that. I know my body. I know what this is. And I said, listen, what you know is that you're numb, but I need to figure out why. And she said, well, I know why. It's from my MS. And I said, okay, but just humor me. Come in. So she came in, and she had a blood clot in her leg, and she had an emergency surgery that night. Right? And so she wasn't having numbness because of MS, she was having a numbness from another reason, and it was actually a very scary reason. And we were able to take her to the OR, and they were able to get that out. My point here is, let's not make assumptions when it comes to your health. Let's not make assumptions when it comes to scary symptoms. And I think the very best way to sort it out is not to play Dr. Google, and it's not to play telephone medicine where you call the MS nurse and she calls you in some steroids or what have you. It's to be seen by your clinician so that they can examine you and try to figure it out with you. Very important point.
Great, thank you. Karen writes, can you go on Mavenclad after being on Ocrevus for 4 years while in your mid-60s?
Yes, I've done that.
Okay, next. Are you involved in a study that you don't possibly need another DMD after being on Ocrevus a certain amount of years?
I'm involved in a registry where we capture information from all people with MS that want to participate, independent from what kind of MS, your age, comorbid conditions, or what drugs you're on. And I really love that registry because it's a way to fight back. It's a way to give information which improves our ability to manage MS and understand MS. And so that's available to anyone on any therapy or no therapy at all.
Great, thank you. Before I get to the last few questions, I want to let people know that on August 3rd, which is, wow, coming so soon, it's amazing where this year has gone, right? On August 3rd, we're doing our next MS Views Now program, which is a program based on multiple sclerosis and COVID, the vaccinations, access to care, as well as things to do with other things. That's all I'm going to go with right now, right? And that is what Mitzi Williams, it'll be this coming Tuesday night. It'll be a 7 p.m., program. So if you can be with us, please go to our website and get registered. Also, we have coming up our PT programs that we do twice a month, Pilates, yoga, and so much more. So again, visit our website, msvn.org, and find what you want to get registered to, if not already registered. Thank you for that. Oh, and next Saturday, again, for those that came on late, you didn't hear that Dr. Boster will be with me, okay, in Roanoke, Virginia, okay? And we are going to be doing a program different from right now. It'll be slightly different topics, but he will be there in person doing a live event, which we will be doing virtually as well. So those that will be in the Roanoke, those that are in the Roanoke area, we're hoping that more of you come out to this program. And for everybody else, we look forward to seeing you live online. All right, next question. We have people want to know why they hear so much about medical marijuana for people with MS. Can you tell them why it is that they would even be using marijuana if they've never done this in their life?
Yep. So medical marijuana or the use of cannabis is a really, really hot topic, right? It's a hot topic politically, and it's a hot topic in medicine. I personally have been a medical marijuana recommender in the state where I practice in Ohio now for about 1.5 years. And I have found 4 areas where I think MMJ can help symptoms. Now, medical marijuana doesn't slow multiple sclerosis at all, right? But it can treat some symptoms. And I find that it can be very, very valuable to treat insomnia, irritability, pain, and spasticity. Those are the areas where I see the most value. Now, I also have to say that MMJ can impair cognition, and that is something that we have to be thinking about. And it's not for everyone. I have had some fantastic success stories with really medically refractory pain, like trigeminal neuralgia pain, that responded to MMJ. And I've had some patients that were cognitively impaired because they weren't sleeping and a gummy before bed, and now they no longer have that problem. So I do think that there's some value.
Right. And I'm just going to add in, I started using medical marijuana a few years back because of pain that I lived with, because of unable to sleep at night, because of other things. I definitely don't overuse. I don't have the time to overuse, and I need my brain to think during the day. So it's not that I use this during the day. But an hour before I go to sleep at night, it's good to do because it definitely does help me get to sleep, helps me get a longer night's sleep, helps me sleep better, and does take away the pain that was waking me in the middle of the night, with spasticity and whatnot. So if anybody wants to talk to me about it and see what it is that I'm doing and how I'm doing it, I definitely don't use much, and I don't need much anyway. I get buzzed very quickly on this crap. So, all right. A couple of questions now coming in. Jessica writes, THC versus CBD. What can you tell us?
I can tell you a lot. I've done grand rounds on this. If you go to my YouTube channel, I have multiple lectures on this. CBD and THC are both cannabinoids. They're both psychoactive chemicals that are found in cannabis, two of like hundreds and hundreds. They're the most common. I can tell you specifics, but check out my video on the topic and I go into extreme detail.
Okay. All right. That's great. Yes, he does do this. And we also have it on our YouTube channel. Dr. Boster, we've had speaking, as well as Dr. Thrower. Both of them give excellent explanations about all of this. Okay. And that's Dr. Ben Thrower. All right. So next question. I'm going to spell the word to you because I don't know how to say it. Please explain dyspnea caused by MS. Dyspnea?
Dyspnea. So dyspnea, the second half of that word means breathe, and the first half of the word means not very good. So dyspnea is when you're short of breath. And you can have difficulty with that from neurological causes if it affects the bellows or the ribs, but it's not very common to have dyspnea from MS. So if someone's short of breath, I'm going to be looking for other causes first before I think that it's an MS thing. Dyspnea is not normal and it needs to be worked up. And so that's something you want to bring to the attention of your doctor. Absolutely.
Okay, great. Another person writes, what can you tell me about the MS hug? I do get pain in my chest.
So again, we have YouTube videos on this, and MS Visa News certainly has YouTube videos on this. What's happening with an MS hug, it's the only hug you don't want. And it's when you have a spinal cord lesion that triggers the muscles between your ribs to clamp down. And it makes you feel like you're being squeezed in a vice. It's super painful. And oftentimes, the very first time it happens, people go to the ER, they think they're having a heart attack, God forbid, or something like that, and it's not. And they get a workup and they're sent home because there's nothing wrong. Well, there's nothing wrong with their heart, but there is something very wrong with their spinal cord, and it results in the ribs clamping down and causing significant pain. Fortunately, it's a very treatable condition.
What can you tell us about people that lose their voice in the middle of the day? There seems like their throat closes up or their vocal cords tighten up on them after they've been talking a lot during the day.
So people impacted by MS can have various types of fatigue. One type of fatigue is they feel tired, like pathologic, I need to take a nap. Other types of fatigue is cognitive fatigue. Other types of fatigue is a motor fatigue, where after exerting themselves, they become weak. And that includes your voice. And so you may find that if you take a nap, you recharge your battery, and when you wake up, you can keep on keeping on.
Okay, great. Thank you for that. Next, Jen writes, why are you having symptoms like tingling after your attack has gone quiet?
Because you didn't fully recover. So when you have an attack and you get better, you may get all the way better or you may get part way better. And so in this example, your numbness got 90% better, and now you're left with residual numbness. And that's an unfortunate thing, but it's a reminder of why you take an MS medicine, because you don't want to have another attack that doesn't fully recover. That's kind of your spidey sense and your reminder of why you're doing why you're fighting so hard.
Okay, thank you. Two more questions. What about the people that are tingling like daily? You know, they have tingling on left side or right side of their body, legs, hands, feet.
So I have a pill for every ill, and I have medicines that treat tingling. Now, we don't treat tingling as effectively as we do neuropathic pain. So if you just have like numb and tingling, like you banged your elbow and it's like kind of sleepy, that kind of feeling, the medicines we use work, but they don't always work as well as if we're treating neuropathic pain. That stated, there's a host of medicines, probably 20 or 25 that I could think of, that treat numbness and tingling.
Right.
Last question.
Can you name one of them?
Gabapentin, Neurontin.
Great, thank you. All right, what did you ask after that? Did you have a question for that?
What was the last question?
Last
that was
question.
my question.
Okay, got it. Okay, got it. All right, last question. No, you're asking me what the last question is. I got it now. Ooh, took a while. See what happens when you don't feel well? Okay, got it. All right, so the last question is, does marijuana help to dry a person with bladder issues?
No.
Only, I guess that was said because you get mouth dryness from marijuana.
Yeah.
Okay.
It does not help with bladder. That's actually been studied, and no, it does not.
Okay. Well, that was the last question. Then I have nobody else. I don't see any of the questions coming in. Well, that's great. Okay. We actually answered all the questions. So I want to thank everybody for being here. I want to thank Dr. Boster for being here. And it was a pleasure to ask him to do this event tonight on such short notice. And he said, yes, woo-hoo. Thank you, Dr. Boster. And again, we look forward to seeing everybody. Get online with us during the week. You will get notices. And yes, I got a lot of people writing in right now. Thanks and blah, blah, blah. You know, so thank you all for listening. And we look forward to seeing you again real soon. And Dr. Boster, thank you again for everything. Have a great night, everybody.
The news, you're an amazing organization. You have really led the charge in driving patient education during a pandemic. And the fact that you've targeted underserved areas is really to be commended. Thank you for that. Thanks for this opportunity. Everyone who's listening, thank you for taking time out to up your game and learn MS with me. And until the next time we see each other, be safe and take care.
Thank you. Good night, everybody.